ڈیمونیٹائزیشن کے لیے کاؤنٹ نہیں ہوگا.
اور اب ایکسٹینڈ کریں, بگ ویو ایکسٹینڈ. گڈ. الٹرا ساؤنڈ بھی دکھا دیں.
Mustafa, we are with you. Okay, can we have the case, please?
Yeah. Okay, good.
Can we present the case?
Audible?
Yeah. Go ahead, son. You go ahead and present the case.
Yes. Assalamualaikum, are we audible?
Yes, you are.
Okay, sir. So I'm Dr. Swasina. I'm going to present the case. This is a 26 years old male with history of chronic pancreatitis since 10 years. He was asymptomatic around 2 years. After around 2 years back, he had a pancreatitis episode, and now around 2 months back. At that time, he was investigated further and found to have elevated IgG 4 of 3880, that is around 1.5 times the upper normal limit. Along with it, recent MRCP was done, which was showing with suspected pancreatitis, suspected pancreatic divism. There was a stricture in the pancreatic head, followed by ERCP, which confirmed the diagnosis of pancreatic divism plus stricture. A stent was placed in June. Currently is here for endoscopic ultrasound evaluation of chronic pancreatitis.
And the stent is through the minor patella?
Yes, sir.
Okay.
Yeah, so let's just reset, go back into the. So we're just at the G junction, and so look endoscopically, make sure you know where you are. And so we're still, so look, find your lumen endoscopically, okay? So go ahead and drop your left hand. So go counterclockwise. Counterclockwise. Keep going counterclockwise. There you go. Now advance a tiny bit. It's okay. There, stop. Okay. Now you can go suction, big wheel towards you, so big wheel up. And go clockwise. And you can pull back a tiny bit if you want. Okay, right there. Now keep going clockwise. Good. Keep going. Keep going. And there's your aorta, right? So I just want to highlight this. Sometimes, if you could show us the endoscopic view just by going counterclockwise. So go counterclockwise.
Yeah.
Keep going. Keep going. Show us the stomach for a second. Up. Can you see the endo view? Yes. So show me the stomach. I want to see the. So sometimes what happens is, pull back a tiny bit. If you start, let me take over just for a second to demonstrate this. If you sometimes come right at the esophagus, you push forward, and you stop here. Sometimes as you go like this, you may have a hard time advancing the scope. You're getting stuck. Here I actually didn't, but when you were doing it earlier. So it's always better to just reassess. Don't keep pushing forward because you can get trauma. You gently advance the scope a centimeter or two. You know that you're past where you really want to be. Now you can suction. You make your big wheel come towards you, and you go clockwise. And if you feel that I'm too far forward based on the portal vein, you can always pull back with a bit of big wheel towards you, and then keep going clockwise for your aorta. So you don't have to force anything at the G junction. It's okay to go slightly ahead of yourself and then pull back as well. Okay? So I'm going to hand it back to you because this is where you were. So take over.
Yeah, so this is a very important point, Mustafa. Thank you. Because the way I was telling everybody, find that celiac axis as cement and go move forward, but scope sometimes.
So I'm at the celiac axis
because
now.
Because of idle hernia or the shape of the stomach. In those cases, just go beyond the G junction into the stomach and then come backwards.
Okay.
And also just imagine that you are in the stomach. One
Yep,
side
good.
is going to be pancreas, other side is going to be liver. So you have, if you're just seeing a liver at the bottom, you have to rotate the
So
floor
now-
to go to the left.
That's the pancreas.
Because pancreas is
Yeah,
at the
that's
bottom, right?
dark looking
Inferior,
pancreas
and liver
with
is on the left.
slightly prominent BD in the center.
Good.
So I'll keep chasing BD now.
Yeah, we're not chasing it, we're following it, right?
Yeah.
So go counter. Okay, good. Now pull back on it a bit. There, and keep going clockwise. Good. So a lot of abnormal parenchyma here. Keep
Yeah.
pulling back.
Okay.
So just for the audience, I'm going to put the flow on.
Is varices in the splenic hilum or just
We
normal
can come back to that, but
Yeah.
I will come back to that. Just
Yeah.
show me the pancreas. So if it's
Yeah.
if it's to the left, what do you do with your scope?
I move it counterclockwise and oh sorry, I just push in a bit.
Yes, good. You relax
In
your
the
big wheel a
center.
tiny bit and push
Yeah.
in. There you go. Now find us the pancreas again, and go clockwise.
So that's
Yeah. So
pancreas.
keep it in view and keep going clockwise till you lose it. So now when it goes down, you have to slightly big wheel towards you, and keep going big wheel towards you to keep it in view, and keep going clockwise. So you're
Yeah.
right about there, you lose it. So you bring up a good point about potentially there being. What's the difference between varices and collaterals?
Varices are the result of portal hypertension basically, and
What are collaterals?
collaterals are smaller vessels that develop around a blocked vessel.
Okay, so varices and collaterals are the same thing depending on where you see them. Anything that is intraluminal that you see submucosal, that's a varix,
Okay.
whether that's gastric or esophageal. Anything that is outside, behind the mucosa, or outside the organ, outside the gastric wall, in the perisplenic region, that would be a collateral vessel. So even on the CT, you will see a lot of collaterals, and sometimes you'll see the fullness in the fundus, and that's your varices. But they're the same thing. It's all about the definition is based on the location, intraluminal versus extraluminal. Okay, so what you're seeing are not varices necessarily. You're seeing collaterals.
Collaterals.
Okay, but this is also a good time when you see that to consider doing a retroflexion endoscopically to see whether or not you see varices as well. Okay, so go ahead and let me just show us go back towards the splenic hilum, and let's just see. The other thing we can do here is you know that you have pancreas, right? So pull back, show us the splenic vessels here. So pull back where you would expect to see the splenic vessels. Okay, good. Now go counterclockwise. So stay on the spleen. Sorry, on the pancreas for a second. One thing is like if you see something like this, you could. I guess my point is that what we want to do is look at the Doppler flow. Doppler इस वाली machine में कहाँ से होगा? नहीं जो वो तो on करें, and I want the waveform.
B mode.
Pulse wave. There you go. What you can do is if you suspect a vessel to be a varix, you could put this on and see. So it's a moving target. Stay in one place.
Okay,
Try not to move this, because if you move the scope, then I can't measure it, right?
Sorry.
No, you're fine.
I'll stay here.
Yeah. So what is this?
Arterial, most likely.
Yeah. So which artery?
Splenic.
Good. Keep going clockwise for a sec. Firstly, if you see splenic artery, the next thing is if that's pancreas, we would expect go counterclockwise for a second. Keep going counter where you would expect to see your. That's okay. You're fine. Let me take over just for a second to demonstrate this. Right. I think your point about the collaterals is valid, but let's see. We have pancreas here. There's our PD. If we would expect to see the splenic vein above or below the pancreas, above or below the splenic artery. Splenic vein.
Above the.
What's closer, artery or vein?
Closer is basically vein, and
artery is closer. Yes. So you expect to see the vein here. You see this big vessel, but you see a smaller vessel underneath, which you're not making an obvious, you don't see those two classic vessels, right? So I think your suspicion is high. So as you were doing, you could go towards the hilum here, and you do see these multiple vessels. Whenever you see this kind of an image, you're absolutely on the right track that could there be splenic vein occlusion, right? And what you can do, similar to what we were doing earlier, now we can put the power wave form on here and see what we see. And all we see is like, it's not a complete flat waveform, but part of it's because of the movement with the breathing, but it's for the most part flat, right? So I think you're absolutely right. That's a good pickup on your part, but this is likely splenic vein occlusion with collateral vessels. Okay, and this, we can try here. This is one big vessel. So we'll do floor here. It's okay to take your time on these things and study them. There's no rush to like complete your exam, because this is why this patient's here. And look at this. This is your classic flat waveform. When the breathing is stable, you can see that that's the flat waveform towards the right of the screen, and that's your venous. Exactly. So yes, we expect this patient to have splenic vein occlusion, and we are seeing collateral vessels. Okay. So now,
moving on to duodenum.
Yes, go ahead and move on. I think you could see the duct. You could try and follow it to go further down towards the neck, but it's okay for now. In the interest of time, why don't we do the duodenal exam? So what is the purpose of this exam? Just for evaluation of pancreatitis? So one of the questions here would be, whether or not to biopsy if the...
Mustafa,
Yes.
the purpose of this particular case was that, we are seeing more and more patients being treated as autoimmune pancreatitis with no EUS examination, with just an elevated IgG4.
Yeah.
And what we wanted to show was that, and also in the clinical setting of chronic pancreatitis. So if a patient comes with chronic pancreatitis, has a high IgG4, is just diagnosed as AIP, and then they've started treatment as well. So we wanted to bring this case and show you that that's always not true.
Absolutely. I think the IgG4 being 1.5 times the upper limit is not a at all diagnostic of autoimmune pancreatitis. This is a young patient with divisum and also younger at age, so you have to think of hereditary pancreatitis, and unfortunately we don't have genetic testing, but that would be a consideration in a young patient before starting somebody on steroids for a very minimally elevated IgG4. In the meantime, you were doing well. You had the duct, right?
Yes.
So let's get back to that position. So, okay, so what do we see here? You want to
Total
point?
conference across this.
Okay.
I think this, I'm
Here,
going
let me-
to,
What is this?
seems like vascular, no, this
It
is a
seems
vessel.
like it, but Doppler shows what?
I'm trying to release, but when I release it, it just,
So you can put your balloon up a tiny bit. That'll
Oh,
help you
yes.
sometimes in these situations. Just a tiny bit. Now suction. Okay, we're gonna get rid of the Doppler for a second. There's a lot of air in the balloon. That's why you got this. So we checked our balloon, but
yes, we did.
yeah, go ahead and advance the scope again.
Okay. I lost the contact somehow.
Yeah, pull back because you have air in the balloon area now.
Yeah.
So pull back, put the balloon up. No, before you go in. No,
Yeah,
come back,
so,
come
okay.
back. Put your balloon up. Okay, there's water. Now suction, push all the way down on your suction button, all the way down.
All the way down. Right.
Okay. Okay, suction the scope. Okay, good. Now go, pull back and look where you are, and then go back into the duodenal bulb. We'll try this one more time. So
Okay.
pull back, again, reset.
Yeah.
We're not sure where we are, you pull back the scope. That's your safe maneuver. Okay, now you know where you are. Now you can suction, advance, and then try again. Good. So now it looks much better, right?
Yeah.
So go ahead, and what do you see right now?
So this is the portal conference,
Okay.
and yeah,
So this is portal vein.
yeah.
The other thing to notice here is that it looks a bit enlarged. That's there may be some hypertension situation going on.
So
What
when-
about this structure here?
This seems like this is again a vascular structure. I think we put a Doppler flow last time and it came
Okay.
out. No.
So what's between the portal vein? Try and get this into the middle. How would you?
Yeah, I'll pull back the scope a bit.
Okay.
Move the big wheel to my
Good.
side and yeah.
And now push forward a tiny bit. And big wheel towards you. Tiny. There you go.
Yes.
That's better. Okay. So what do you think? What's usually from the bulb between the probe and the portal vein with no flow?
PD. Basically, CVD is expected to come from above.
Okay. So why don't we
It's
try
quite
and go?
dilated and
Why don't we go counterclockwise here?
yeah.
Okay. Try and maintain that view. I'm going to turn this off. So push the scope forward. Relax. Now relax your big wheel away from you. Good. And keep going counter.
Yeah, so that's probably CVD coming from above. And this looks like a PD to me, which is rotating around the...
Well, we haven't done much rotation. Why don't you follow this counterclockwise?
Yeah.
Up into the left. Okay, where is that going?
It's going just behind the portal vein.
Okay.